Thank you very much. Well, good evening, everyone. This is a bit of a fast romp, I guess, through a number of different abnormalities that you will come across. There are, of course, plenty of other things out there, but hopefully this will give you a good idea of what there is out there, what you can look for, and then hopefully a bit of an idea about what you can do and some options, some decision making. What I've put here is a list of a number of different abnormalities. Again, not exclusive by any means, but a number of different abnormalities that you might come across, and then equally a number of different potential treatment types. So some of them are, of course, more obvious than others. We've got things like, okay, of course, if we've got an oncological case, a jaw fracture, we're looking at maxillofacial surgery. And for many abnormalities, we'll be looking at extraction ultimately. But there are other things that we can do, and it's as well to be aware of it because our clients are becoming increasingly aware, particularly with the internet, of course. They can go on there and start looking at all sorts of fancy things, many of which might actually not be such a good idea, but some can be very much an appropriate option in certain cases. So we start to get into things like endodontics. One of the main elements of that will be root canal therapy, root canal treatment, and then restorations, fillings, various periodontal treatments such as periodontal surgery, and then orthodontics where we're looking at moving teeth, altering the shapes of mouths and things like that. So there's a lot of different things that are out there, and just having some knowledge of that is useful so that you can talk to your clients, inform your clients, and also make sure that your clients can make informed decisions and consent. And why are we so bothered about this? Well, ultimately because of pain. So many things in the mouth with teeth will cause extreme levels of pain. And some of the ways that we work out what's going on in our human patients is to look at what they're complaining of, the severity of the pain that they're in, and then also, for example, whether painkillers have had any effect. And for many things, actually, painkillers just don't touch it. So, for example, if we have an abscess, then throwing painkillers, morphine, etc., it usually makes absolutely no difference whatsoever. And we use that as a bit of a diagnostic tool. Of course, we don't have that available to us in terms of the feedback from our patients generally, but it is something to be very aware of. And a lot of the reason that it's so painful in the mouth, or potentially so, is that we have the pulp of the teeth, which has a default setting of sensing pain. It's got lots of different nerve fibers, but really the only thing it really does sense is pain. So we don't have the usual sort of thermal pressure, etc. It's pain or not, or degree of pain. And then we've got a very large part of the brain that is sensing the area of the face from the trigeminal nerve. So that's feeling the face basically, and then feeding, of course, onto the brain and that big area. So something that's capable of feeling really pain only, and then lots of the brain actually dedicated to feeling that area of the body. The net effect being something goes wrong, it's very often extremely painful. We also have to think of these abnormalities and the systemic effect they might have. So that might be a chronic inflammation, it may be the spread of infection, and of course that can affect other organs. And of course, if you're not eating normally, although unfortunately for us, most of our patients do at least appear to eat normally, which can make it difficult to often convince patients, owners, and also sometimes colleagues that this is a problem and it does need to be treated. But it can have an effect. It can make an animal eat to a lesser degree and therefore cause compromise via that route. So really the basics of examination in the mouth are, of course, a periodontal probe with its atraumatic tip, which we use on every single tooth. So that's going to go into the sulcus, so between the tooth and the gingival margin. Run around each tooth to detect any abnormalities with that, and then the sharp explorer probe with its needle type tip, which we only use on hard surfaces, of course, and even then only if we feel it's necessary. So this is if we think there might be a hairline crack, caries, it could be assessing wear, it could be resorptive lesions, but it can cause damage actually. So with both these probe types we need to be careful. with the perio probe that we don't apply too much pressure and therefore damage already inflamed tissues, and also of course therefore get a wrong reading if we go too deep. And with Explorer, because it's sharp, it does scratch enamel. So if the enamel looks absolutely okay, you've got no reason to use it, then don't, only where necessary. And of course we then transpose the information we get from these instruments and what we see as well onto a chart, and that's our map of the mouth, and can hold a lot of information in a very succinct way. And of course we're going to twin that with x-rays, but really to go on to the abnormalities, what we want to do first of all is assess trauma. So this is a really common thing for us to find in our species, and fracture of teeth is frequently a result either of catching or trying to pick up inappropriate objects. So for canine teeth, as you see at the bottom there, that will be typical of an animal that has caught a stone, RTAs, high-rise injuries, that kind of thing, but it would always be some sort of a blow at the front. And you'll notice on that particular photograph at the bottom there that we've got a fresh fracture of the canine, and that's actually gone subgingival, and we've also got an old fracture of the second incisor. If we look at the carnassial, we've got a classic pattern there, which is our buccal slab fracture, and typically because this is a sectorial tooth, so it's sectioning the food, it's one of the main chewing teeth, then we would typically get that sort of injury from something like an antler chew or a bone or some of the very hard nylar bones. So which tooth is fractured will often give you a good idea as to how it happened, and therefore you can guide the owner in terms of what is appropriate play, for example. These are both complicated fractures, so although you can't see the pulp exposure on that upper carnassial, if you were to remove that slab you would see that the pulp is exposed, and you can clearly see that it's exposed on the lower photograph where we've got the canine. Fresh fracture, you would normally expect to get a little bit of bleeding from the pulp, and then that will cease and you'll have the pink pulp initially as you see there. Given time, the pulp becomes both inflamed and gradually infected. We eventually get our pulp necrosis, and then you'll see a picture far more similar to the incisor. When you have a fresh fracture, it's the pulp inflammation that causes the toothache, so that is pulpitis, and it's not really a question of whether it will happen. You will have pulpitis. And the problem with a tooth, of course, is that it's a rigid box. So as soon as you get any inflammation and an attempt to swell, the pressure builds up massively, and that's what leads to the pain. If you have actually quite a big exposure of the pulp, oddly that can be helpful, if you will. Of course, we don't want a fractured tooth, but if it's going to happen, at least if we have a big exposure of the pulp, there is somewhere for that pressure to go. So often you'll find that actually it's the very tiny pulp exposures that would cause the greatest pain. So we go through toothache of pulpitis, and then eventually, inevitably, our pulp goes on to die. And once we've got this irreversible process and we then get necrosis, there'll be a period where the pulp is dead and therefore painless. However, unfortunately, what we're getting with our necrosis is also infection, and eventually we then start to get inflammation around the tip of the root, around the apex, or periapical inflammation, periapical periodontitis we call it as well. Now you can see that on an x-ray, but that's when we start to get pain again, and that is a typical sort of throbbing, boring pain that no painkiller is going to address. And in fact, in those cases where you have suspicion of abscess, or of course evidence of abscess, antibiotics are going to be a lot more useful. So early days, early pulp exposure, you might be reaching for painkillers, non-steroidals, etc., provided it's safe to do so. Whereas at a later stage, from the point of analgesia, in fact, the antibiotics would be more effective. However, in any of these cases, of course, it's not our definitive treatment, and you've only really got two options. Either this tooth has to come out, or we need to get the pulp out, because, as we've already alluded to, it's the pulp that's going to cause the pain. So we can get the pulp out by taking the tooth out, or we can get the pulp out by getting the pulp out, which we call extirpation, leaving effectively the tooth as a shell behind. And provided the attachment to the tooth is good, and I would also say that there's a decent amount of tooth left, and it's an appropriate patient, an appropriate client, then root canal treatment can be a suitable treatment. Now, of course, not